What's the problem with RDBML?
Long lasting, delayed onset, and it can also interfere and do something with the
Because I was at this course with the Royal College and
Everybody's got preference.
they said they just do infiltration with body and that's it. It works for even endo and whatever they want.
It can. I don't use. Because there are recent papers with the nerve toxicity with RDBML. Okay, so I'm not really comfortable. Let me tell you a scenario. For me, ID block is a very bland injection. I'm going from here, I'm going from this premolar, I'm hitting the bone, then I'm making the needle straight, and I'm not going forward, and then I'm hitting the bone. Oh, I have hit the lingula. Did you? No. Have you? Nobody knows. And then you inject. For me, it's a very bland injection.
Of course, it is a problem.
All I'm doing is calculating in my head, this is wrong, this is wrong, this. And if you see mandibles, if you do cadaver dissections, which I do quite regularly, the height of lingula is quite different. The height of ramus is quite different. This is quite different in all the individuals, all the ethnicities. So how will you, a standard technique will make you hit the lingula? I'll tell you a story. The patient was referred to me for low right 8. I gave an ID block. It's pretty much ID block, and that was about 2010, about 9 years back. Gave the ID block, took the elevated the tooth. That's fine. Patient was away. 3 days, patient came back with limited mouth opening. The mouth opening was 2 centimeters. I assumed in my head, okay, I must have hit the muscle, I must have hit the artery, hematoma formation, it will take time to resolve, patient was reassured, documented properly, everything was done, hot water application, warm sponges, everything, analgesia, everything documented. Called the patient back after 1 week. Patient didn't came back. Got a letter from dental no partnership. Did I know what did I hit?
Medial delivery.
Oh, what? Yes, that's my assumption is as well. So what I do is infiltration, make use. Do you know how to get the buccal block?
For the lower.
Yeah. Of course you're going to do the buccal block for the lower. Long buccal is in the mandible, not in the maxilla. Do you know how to get the buccal, long buccal block?
Yeah, just on the retroclavicular area.
Okay.
The distal and like you need lower left 8.
Yeah, you're right. So parallel to the teeth, you hit the external oblique ridge 10 millimeters above the occlusal surface of the last tooth. So you parallel to the teeth, you go straight, you hit the external oblique ridge, and that's where you get the buccal block.
10 millimeters.
Yes. That is your long buccal sorted. Then I use the same technique for buccal side and same technique for the lingual side. But remember, I said I inject in attached mucosa, not in loose mucosa. Loose mucosa is where you have got the lingual nerve. Attached mucosa, do you have any important nerves and arteries in attached mucosa? Not in the mouth.
That's a very tight area.
Yes, it is. You may have to go mesial and distal. In the papilla, mesial and distal, and inject it. And that's what I do for my implants. Buccal, infiltration, buccal block, lingual. But I don't say that you should stop doing ID block. I'm not saying that. I'm saying, think about it, not always start with ID block. You may have to start like this and then if you do not achieve anesthesia, you go for ID block. Okay, ID blocks, we have been doing hundreds of ID blocks in our lifetime and nothing has happened wrong. Okay, so it's very predictable. But what I'm telling you is, use this technique first, and if it doesn't work, then go for, you've got your ID block anyway. You've got your articanes anyway. Okay, by the way, the research is, there was some papers which says articane is neurotoxic. Later on the research, there's huge number of papers which says it's wrong. Okay? So but there are some papers which says articane is neurotoxic. Okay? So people use articane all over the world. There's no problem with it. So infiltration with articane, absolutely fine. What my point is, stay away from the nerve. You need to know where your lingual nerve is. It's in the loose mucosa. So if you do not inject in the loose mucosa, you're not injecting in the nerve. Stay in your attachment. Mental nerve. Where you know where the mental nerve is?
Just applicable to the fly in that area.
Thumb, use your thumb. Middle 1/3 and lateral 2/3. Your superior orbital margin. Feel it. Feel it. Medial 1/3 and lateral 2/3. What can you feel? A notch. What is that notch? You're not normal. No, not, look here, not there, here. Superior orbital margin. Okay, what's that notch? Stop eating shawarmas. It's all in the kebab. Okay, so what is that notch? Superior orbital notch. Okay? Superior orbital foramen is further behind, that's superior orbital notch. Superior orbital notch, nature has been very symmetrical. It's us who does not visualize that or realize that. So superior orbital notch, infraorbital margin, 5 millimeter below the infraorbital margin is your infraorbital foramen. And mental nerve, all are in one line.
This one should be where the
And that's where you inject your intraorbital nerve block for sinus lifts. Where is mental nerve? Mental nerve is present between 4 and 5.
right of completely down to these three.
It's all one line. Nature has been very symmetrical. Has been very honest, very symmetrical. All the bad thing lies in us. So one line. So that's where you give your, if you feel this is your infraorbital nerve. And that's where, if you feel it from inside, not far from the buccal sulcus. So that's where you inject your sinus graft for sinus grafting. So intraorbital block for sinus grafting, that's it. And mental nerve is going to give you anesthesia for, so between 4 and 5 is mental nerve. For lower interiors, I use infiltration, that's it. Lingual, buccal, that's it.
Patients sometimes do still feel some
Why?
pain.
Why do infiltration? If I'm doing implant, you're absolutely right. If I'm doing an implant in lower right 1, the patient will feel pain after infiltration. Why?
There's sometimes it has to move from the other side.
Very good. That's the only area where you've got collateral anastomosis. Nerves are coming from the other side. So in that case, then what I do is mental nerve block other side. That's it. That's the only area where you have collateral anastomosis. Everybody clear with anesthesia? Yeah? We'll later during the course, we'll go through, when you're going to go through the patient, we'll do it on the patients as well. Okay? Not you individually, but I'll do it and you can. Okay, when would you perform minor surgical procedure implants in your practice? It improves the practitioner confidence. Okay? It gives a greater joy in the practice. When we're doing implants, nurses are all hyped up. They want to see the blood, they want to see the elevator, they want to see the bone cutting and all of that. So it's a greater sense of joy in the practice, okay? It brings the practice up. And you stretch out of your comfort zone. That is very important, man. It's up to you. You want to be a GI fitting dentist, you want to take the risks. Okay? For me, if my life is not challenging, I'm not going fast enough. I want to make it challenging. That's it. There has to be a challenge. And that's how you develop your career. Or when the opportunity knocks, this poor lady is asking for a hair dryer. I'm not going to go into this detail because you're a dentist, you should know how to do the full examination. So that is, this is ASA classification. Most of the times you're going to see ASA 1 and ASA 2 patients, which are fit and healthy, no problems. Okay? ASA 2 patients with a medical condition that may complicate the delivery of care, but is not going to affect the outcome. So outcome is not affected, but it can complicate your delivery of care. For example, patient with hepatitis.
Previous
Yeah, of course. Past history of endocarditis. The outcome is not going to change. Okay? Steroids, epilepsy, medically handicapped. Uncontrolled diabetes is ASA 3. Controlled diabetes is ASA 2. Because it's not going to change the outcome. But uncontrolled diabetes is ASA 3. Now, ASA 3 is a medical condition that may additionally compromise the outcome. Complicated surgery, uncontrolled diabetes. Coagulopathies. What do you mean? What do I mean by coagulopathies? Blinders.
Where you get like the clots in the blood.
Something with blood.
You're going to get a proper bashing during this lecture now. All of you. Immunosuppression. If the patients are on immunosuppressive drugs, then it's ASA 3. ASA 4, you're not going to do it. ASA 5, not relevant to you. So 1, 2, mostly, 3, rarely. ASA 4, 5, you don't use it. But ASA 1, 2, regularly. ASA 1 regularly. ASA 2 commonly. ASA 3 rarely. Okay? Everybody clear? With this new contract coming, there should be a prevention advice in your notes. Okay?
Which new contract?
The new contract which is coming, the pilot contract.
Is it coming?
It is. But the times are different. Anyway, GDC is getting big on these, on prevention as well now. Everybody is getting big on prevention. So you need to have, although having said that, I often hear that I am here for a dental treatment, not for ethical lectures from patients. I don't mind, I just put down in the notes, patient informed, so and so, that's it. That's my job done. I don't mind. Okay? But this should be there. Obesity, 30% of world population is obese. WHO has classified it as a chronic disease. The problem is not the patient weight. The problem is what comes with it. Okay? Cardiovascular diseases, heart disease, cardiovascular diseases, then coagulopathies, and so on. Okay? So, the new contract which is going to come will have direct advice as well. Okay? So, I think let nurses do that. Okay? Because they can speak to the nurses in a more friendly manner than yourself. They take your things as offensive. Okay? And nurses, they can liaise with them. They can actually collaborate with them very well. So sometimes if they cannot say anything to you in the surgery, they will come out and reception and no, start doing it. Okay? So let nurses do it. Now, What are the cardiovascular diseases you're going to see your patients with? High blood pressure, which is called hypertension. Okay, what else?
We have people with angina as well.
Please.
Ischemic heart diseases. What are ischemic heart diseases? Angina and MI is ischemic heart disease. Ischemic heart disease is when when heart muscle does not get blood. That can be due to angina, but that's a condition, angina or MI, but that's because of the blockage of arteries. Okay. Hypertension is blood pressure, you all know about it. Cardiac failure, inability to maintain the sufficient cardiac output. Okay. So these are the patients you're going to deal with. What you going to do with the patient of angina? Patient has angina 2 months back. Heart pain 2 months back, comfort extraction. What are you going to do?
Use the lip
First
anesthesia
ask what
without-
medication he's taking.
Okay, patient is taking aspirin and lisinopril.
That's still alright.
Yeah, okay. You think anything you're going to get prepared for?
Well, I think the GT is, we need to have some medication.
I think of you are sure.
Yeah.
Dealing with lives.
No, sure.
Yeah. Definitely, I think I'm sure.
And keep some local measures ready if it is required.
Look, patients should be treated. By the way, this lecture, there are very few lectures I can send you by email because I don't believe in giving you cooked food. I don't believe in this kind of teaching. I want you to do the research, do the struggle and learn it yourself. I'm not going to give you spoon feeding. You're not kids. You're postgraduate students. You're dentists. So no spoon feeding from me. Bad may do it, Sazeen may do it, but not me. So this is one of the few lectures I can email you because this does not have my patient pictures. Otherwise, all my lectures have got quite a lot of patient pictures. So, okay, it says that you should be treating patients late morning and early afternoons. Why is that?
Because they sometimes develop symptoms a little time after treatment.
Who of you give plain injection for cardiac patients? Well,
Yeah,
without
without
everybody.
Sometimes.
Everybody does. I know everybody does. I don't know about you, but I know they do. I don't. Why do you give plain injections?
Adrenaline can go to the bloodstream and then it goes more.
What does adrenaline do?
Increase the heart rate.
Yes. Do you remember the flight and fright response? Yeah. By seeing your blank faces, my adrenaline goes up. So I'm getting for fight or flight response. Yes? My body is secreting adrenaline. Okay? I get patients who come to me and say, you know what, I'm allergic to adrenaline. Don't give me that injection. I just laugh in my head. How can you be allergic to adrenaline? Your body is secreting adrenaline. But the dentist have told them. Our dear, knowledgeable dentist has told them, don't use this cartridge. You are allergic to it. So they will come and, oh, you know what? There's a specific type of cartridge I've been told I shouldn't get and I'm allergic to it. Okay. Yeah, okay. Okay. Your body is secreting it. Okay? Now, how much cartridge adrenaline is present in your cartridge? 1 into
80,000.
80,000 in a 2.2 milliliter cartridge. And do you think, if you do not get proper anesthesia, how much your body is going to secrete? More than that. A lot more. Yeah. So it's better to give xylocaine with adrenaline and achieve proper anesthesia rather than getting plain and not achieving local anesthesia. The only problem is, as Asif mentioned, if it's get into the blood vessel. if you inject adrenaline containing xylocaine adrenaline inside the vessel, that can affect heart rate.
That's
To
what
avoid-
patients think that they're allergic.
Yes. To avoid that, what you do is self-aspirating syringes. The moment you see the blood in your cartridge, retrieve. You don't inject in vessels. So that's why I only use xylocaine with adrenaline. There's no playing in my career. Okay, I don't inject into vessels. Okay? Now, what happens when you have a heavy breakfast? 4 sausages, 2 eggs, and bread and all. What happens after that? That's where the body is secreting less adrenaline. And that's where you treat these patients. After breakfast, after lunch. So when body is secreting less adrenaline and not asking them to pump their heart more. If they ask, the body asks to pump the heart more, their heart is already weak. So you treat them when their circulating catecholamines are lower. Anxiety reduction protocol is very important. You need to tell them to calm down so that your body secretes less adrenaline and you can work better. Okay? Money should be taken with LA with epinephrine limited to 2-3 cartridges with aspirating syringes. Okay? LA with adrenaline is fine. No point of using any cartridge. Cardiac failure patients should be breathless, so they should be treated more upright. Okay? Antihypertensive. Patients on antihypertensive, they shouldn't be raised up at once because they get the postural hypotension. Okay, so these should be raised in stages. So hypertension, the chances of bleeding. Okay, because blood is pumping out. Chances of bleeding, so hemostatic agent should be used. Angina, what you going to do for angina? The patient, you're given anesthesia, the patient has got heart pain, what you going to do?
GTN. That's why we have a
Where are you going to put the GTN?
in the oh no, something.
How much spray? 1 spray, 2 spray, 3 sprays, 4 spray, 5 sprays? 2. How much dosage you are administering with 1 spray? Okay, have a look into it. If the patient does not, the chest pain does not go away, what you going to do again? After 5 minutes, you're spraying underneath the tongue, patient is still feeling chest pain, what you going to do?
Aspirin.
Do you do another GTN? Yeah, call 999, but again, they're going to take 5 to 8 minutes, 10 minutes.
Hopefully.
Yeah, but did you do another GTN? That's my question. Why not?
Yeah, why not? Nothing wrong with it.
Why not? What does GTN do? Dilate the blood vessels. So it's going to dilate the blood vessels in heart only, or tongue only, or all over the body? If it does it all over the body, what happens to the cerebral arteries?
They also dilate.
And then more blood. So if you dilate, where to dilate? They can rupture. If they rupture, what's going to happen? Stroke? Thank you very much.
So you don't do the same.
Don't go crazy with those. Okay? Don't go crazy with GTNs.
So 1 spray.
Yes, usually that does not happen quite often, the rupture of cerebral arteries. More often is tension headaches, because too much blood in their head, so it gives them headaches. If you've got too much GTN, then it gives you headaches. Okay? So don't go crazy with your GTNs. Recent MI, up to 6 months, no general anesthesia. Okay? As a referring dentist, you know that you can be held responsible if the patient goes under another MI under general anesthesia. There was a case where the dentist was referred